So thank you for inviting me. Thank you for Professor to be there and allow me to speak a little bit about the breast, because I know that is very well known in breast surgery. So I hope I can give you my experience. So as you already know from the previous presentation, basically the breast implant pocket has a very important impact in the patient decision results, especially because we can decide, when we decide the pocket that we want to make, also the future of the implant. Because depending on the submuscular or subglandular pocket, we know that we can influence what the result can be over the next 10 years. Because now we have implants that last so long. So basically we can imagine that maybe the result is perfect at the beginning, but over breastfeeding and augmentation of the fat of the lady or losing fat, we can affect the result of the implant. So we have many different transformations. Yes, it's this one, right? It doesn't want me to. Yes. Okay. So actually, not only the static appearance is considered for the patient is important, but also the dynamic one. Because we go to the gym, and we don't want to other people understand that we have implants when we make our exercises. So especially in very active women, we generally put the implant submuscular, and these are the patients that can be affected mostly by the position. From the history, now we know everything, because Professor already showed us that we can have different type of implants position, subglandular, under the muscle, under the fascia. And of course, there are side effects, pros and cons, considering all the position that we choose. Of course, in the submuscular pocket, we decide to put the breast implant in this position where we have not enough coverage on the gland, over the gland. And for that reason, we have a tendency in some patient, in some type of surgery, for the breast implant to migrate a little bit upwards. So we have a major fullness in the upper part compared to the lower. This is one of the side effects of the regular complete submuscular, especially when we do not define in a special and in particular way the submammary fold. So we have not a very good and well-defined inframammary fold. And for that patient, we have a very high incidence of deformity, breast deformity. This is Tebet's. You know everything about the Tebet's technique because Professor already showed you, but we want to fix what is breast deformity. That is also called as BAD, breast augmented deformity. That is another recent issue for patients, and this is one of the major complaints in the submuscular and dual plane position, because patients are very happy in the static, but they can see this deformity after moving. This is one of my patients that I was operating for at least, I think, 10 years ago in the regular dual plane manner, but you see the breast deformity. So many patients do not complain about that, but some others now are really understanding this problem and want to be corrected. So what we know from actually the literature is that reported from Spears that this deformity is present in 53% of the aesthetically performed breast implants, but is even worse in the reconstructive ones, 75.6%. So it's a very high incidence with the regular dual plane and submuscular surgery. Is considered not only cosmetically, but also from a point of view of a medical issue, because some of these patients complain that they have pain during the contraction because of this dynamic deformity. So we have many treatment options from the literature. They propose neuromodulation, so to block the muscle, selective nerve transection, that is quite invasive for this, repositioning of the implant, so bring the implant from the bottom to the top under the gland. But for sure, this is not an option for many patients, because if we decided to put the breast implant under the muscle, it's because we have not enough coverage. So this could be a possibility, but in the United States, they do this and they combine with fat grafting, so it's a very long procedure. They do fat grafting first, then do change the pocket after, so it's a very difficult option, and various splitting options in which we see from some authors, they split the muscle all along his length to avoid the contraction, and the use of meshes. But this is very bad, very terrible, bad severity evaluation. This is a kind of 3-degree of deformity. You see, in the normal regular position, the breast appearance is fantastic, but when they contract, they see this. And of course, especially for sexual or activity, many patients complain because maybe the partner can understand they have the breast, even if the breast is very soft. So what we now want to understand, there are different grades of deformity, no existent, moderate deformity, so just a little alteration of the breast. You can have a dynamic movement of the breast during the muscle contraction, but is not considered a deformity if the breast itself doesn't change the shape. Because some patients, they have also this dynamic contraction even without the breast implant. But if the shape of the breast changes, it is considered bad deformity. In the grade 3 is very, very severe, like the other one that we saw. Okay, so we have different type of description to avoid this deformity in the literature. The one that I studied, because I wanted to study a little bit more about that before starting doing the surgery, so I tried the different technique that you see. The first one is the one from Mario Pelliceravolo. He published it in 2004, and the access for the breast, as you see from here, I will stay there, is periareolar dissection, subglandular dissection. So we do the subglandular. We arrive at the level of 1 centimeter above the nipple areola complex for the glandular dissection. Then we access from the intramammary fold the muscle. So we lift up the muscle and we make a transverse incision, as you see from the drawing, at the for the muscle of the major muscle under the nipple areola complex. As you see here, this is the dissection, this is the cutting. In this way, we avoid the triggering of the contraction and the changes in the shape of the breast. Then we have a second possibility that is proposed by Roberto Bracaglia and published in Aesthetic Plastic Surgery in 2013, and is a different approach in which he makes a submuscular access through 5 centimeter blunt dissection in the lateral aspect, like the regular undermuscular technique, so it comes from the side. Then, as you see from here, there is no undermining of the breast parenchyma at all. Pocket is described under the elevation of pectoralis major muscle, serratus, oblique, and rectus. So it's a very wide dissection in which we have a very good coverage of the breast implant that will really give long-lasting effects of the coverage. Then he makes this horizontal full thickness incision to access the pocket and this cutting to avoid the breast deformity. What he described in his publication that is very interesting, and I do suggest you to take it and read it, is that basically in the regular pocket, when we cut in that level, we increase the triggering effect of the muscle. This is why the breast is shifted laterally during the contraction. But when we do this dissection, basically we avoid the contraction in that area and we allow only the horizontal. So what we have during the contraction of the muscle, according to Dr. Bracaglia, is that the breast implant is only pressed toward the thorax instead of shifted. So we decided to modify the technique because we thought that basically both of them had some problems. The first, we make our incision from the nipple areolar and we do not access from the submammary fold. And secondly, basically, we wanted to have this full coverage. So what we do actually is a periareolar dissection, subglandular dissection till the upper areolar, like Pelliceravolo. Then we do again the muscle incision at the inframammary fold, but we make and dissect a wider pocket, because we really want to have a long-lasting effect and to reduce the limits of the technique of Mario Pelliceravolo, that was the lack of coverage. And we do, instead of a vertical, we do a transverse incision. So basically, we dissect in all this area, and we cut a very long line in this direction. What is good is that you can accord the level of cutting depending on the size of the breast implant. So if you have a very small one, you make a smaller cutting. If you have a wider, you can cut more, but you still have coverage in the medial, lateral, and lower position. What are the advantages? So higher coverage, and we already talked about that, the possibility to extend with the longer incision according to the size of the breast implant, the possibility to reduce the medial space between the breast. So instead of having this wider space in between, that we don't really like when we have breast implants. We want to have closure in this area. We reduce the possibility to have an upper pole dislocation because we access from the lower side. So it's impossible to not define in a good way the inframammary fold. And what is nice is we decompress completely the area around and under the nipple areola complex. What we have immediately after the regular breast implants in the dual plane, we have this area that is completely flattened because of the compression of the muscle. And patients don't like because it looks like round. But when we do this cutting immediately after the surgery, we have this projection of the nipple areola complex that makes the breast appearance nice from the beginning. So it's also very easy to make revisions. So I will show you also the revision of my previous patient. So what we involve in this technique is a wide range of muscle. As you know, is a pectoralis major, the serratus, rectus abdomini, because we need to dissect the fascia of this, and the oblique external muscle, because it's involved when we want to lower the inframammary fold. This is the technique. You see all the muscle elevated and the breast implant underneath. And we need to cut then transversally under the nipple areola complex. This is the patient of the revision surgery that you saw. And basically, we have a full coverage. You see the muscle is basically medial, laterally. So covering all the muscle, all the breast implant, like in submuscular total pocket. So it's a very high and wide coverage. And then we cut the muscle in this direction, so transversally under the nipple areola complex to release the breast implant completely. So this is again the technique that you saw, just to have a remind. And the results. So this is the result in a static position, but we want to check also dynamically. You see that during the contraction, there is no movement of the breast implant. Also in very athletic, she is a personal trainer, submuscular total pocket. This is before and after immediate result, and this is after contraction. I hope I will show you. Yes. You see the contraction, there is just a little bit in the right breast, but so little, because of course it's the more active muscle and side, but basically nobody can understand that she has the breast implant, and we also close the intramammary space. This is another patient, also with the arms lifted up, and this is during the contraction. So basically, again, is not considered breast deformity because it's so little, the deformation, that is not considered as a pathological one. Again, another one. See, no deformation at all. And we have a full thickness coverage in the upper and the lower pole. This is the previous patient that I re-operated with the breast lift around the nipple areolar complex. You see, this was before the surgery, and this was after. So we can also correct the breast implants deformity after we already did a regular dual plane technique. He is Mario Pelliceravolo, he's one of my closest friends, one of my teachers also. And so I hope you really want to change maybe a little bit your technique to avoid this type of deformity. Thank you so much.
I want to ask you about the periareolar incision. I did this only when I have to reduce the areolar or when I have tubular breast, but are you happy with the scar?
In my experience, I started both the treatments, the submammary fold one and the periareolar one, and I have a different degree of scar deformity in both cases. But while the periareolar do not really stress the patient a lot because they can cover when they are in the summertime or wherever, when the submammary fold one is bad, it is really evident when they go to the beach, and so this is the reason why I switched it, because females are more concerned about the bad experience and appearance of the submammary one instead of the periareolar. But very often I do revision surgery for both of them.
Thank you. My opinion is the nipple areolar complex is very important in ladies' life, even sexual life. So an inframammary approach is more acceptable and also allow you to go back for revision surgery from the same incision. So congratulations. Anyway, I will keep my way. So,
but anyway, you can do also from inframammary. There is no problem. The access is not the technique. You can access from the submammary, you can access periareolar. The important thing is if you want or you don't want to have the breast deformity. So this is just, I let patient to decide about the access.
Mm-hmm.